BNR, when will you start? It is already 8.
We'll start now only. तीन पीजीज तो ज्वाइन कर लिए, 3 रेजिडेंट ज्वाइन किया और एक पैनलिस्ट ऑलरेडी इज देयर एंड आइजक क्या सुनील है क्या, कौन है सुनील? हेलो क्या नाम है आपका? एडमिन क्या नाम है? चलो कोई बात नहीं, हम तो शुरू करते हैं अभी। आप थोड़ा एक तरह की ये जो काउंट डाउन दे के थोड़ा स्टार्ट करो। हेलो, कैन यू हियर मी? हाँ, काउंट डाउन देके कर शुरू करो। Is it live now, admin? Hello. Yes, sir, we are live. We are live now. अरे क्या बोलना चाहिए था ना, it's already. Okay, thank you. So over to our secretary, Eizoc, Dr. Devasji.
Good evening, everybody. It's a great pleasure to have our Eizoc sessions again back on track. This is the 36th episode, and today we will be discussing on the examination techniques in neuroophthalmology by none other than the most dynamic Dr. Rashmin Gandhi. I welcome Rashmin to this activity of ours, which usually occurs every month in the Eastern Zone. Along with that, may I welcome our moderator today, Dr. Aparna Dwivedi. I'd like to thank our mentor, Dr. Ajit Babu Majji, who has been masterminding the programs over the years, and I'd like to great thank to our chief coordinator, Dr. BNR Subudhi, and our co-coordinator, Dr. Sabyasachi Patnaik, for organizing this webinar over the years. We have a very star-studded list of panel: Dr. Sharmishta Behra, Dr. Haimanti Chaudhary, Dr. Soni Sinha, Dr. Amit Kumar, Dr. Supriya Hawaibam, Dr. Sunil Kumar, and Dr. Randhir Jha. I welcome you all, and I welcome all the discussants who will be highly benefited by the program today. With this, I hand over the session to Dr. BNR Subudhi, sir.
Request our president, say a few words. Dr. Jayan sir.
Hi, good evening, everybody. It's a great pleasure to have the Orts back after a gap of about 2 months. Actually, we really missed this program, and this was very helpful for all the PG students. In a very recent visit to AMC, Assam Medical College, few of the students had asked me, "Sir, why have you stopped this program?" And I had very difficult answering them. And they were greatly benefited. I welcome all the speakers and all the panelists, everyone here, and we anticipate for a great learning today. Thank you.
CSC, Dr. Nitin Dira.
Yes, sir. Thank you, first of all, for resuming the program. And this is very significant program, we all know. Thank you, Ajit Babu Majji, sir, and BNR, sir, for bringing this program again. This is very much essential for the residents, especially, keeping in mind, and this is the program which is going to be, benefited to benefit most of the resident in this part of the country. So with this, I believe that everything has been said by the president and secretary, sir. So we should begin the program. This is a very important topic for resident point of view, neuroophthalmology. So
thank you.
Over to you, sir, again.
Yeah, thank you very much. So let me give the details, little bit details about our today's program. So I welcome you all to this Eizoc Orts 36 series. Once again, I thank our President Eizoc, Secretary Eizoc, and CSC Eizoc to be present in this webinar. And due to some reason, for a pretty long time, this was stopped, paused. I would say it's not stopped. I would say paused for 2-3 months. But now again, we are back again to the thanks to President Dr. Jayant, who has stimulated me, and Dr. Pranabji also, who has really stimulated me to start the program. So accordingly, we started the program from September onwards. And this time we had chosen a topic, neuroophthalmology. It's a very interesting topic. And to start with, our opening batsman, Dr. Ashwin Gandhi, he will be describing examination techniques in neuroophthalmology. So it's really pleasure to have this program once again. These are our team. And I thank again, once again, our President, Secretary, and Chairman, Scientific Committee, Eizoc, to continue this program since a long time. And I think over the time, it will also continue for another few years. And of course, nothing more to say about our mentor, Dr. Ajit Babu. He is well known in the Eastern sector. And I think Ghar Ghar mein wo present hai, whether it's a resident, whether it's a faculty, whether it's a professor, whoever it may be. So Ajit Babu is really great friend to us in Odisha also. So he's really mentoring the programs, which are the programs, which are the speakers for this episode. Really, it's wonderful. So thank you, Dr. Ajit Babu, who remain with this program. And of course, my co-coordinator, Dr. Sabyasachi Patnaik, is always with me. We have started this program a long time back, maybe 3-4 years back from the state itself. Then we made it a Eizoc program and covering almost all the 13 states of Eastern Zone. So today's speaker is Dr. Ashwin Gandhi, and I will request our moderator to introduce him. And I want to introduce him. And our moderator today is Dr. Aparna Dwivedi. She is very much well known in Odisha as a consultant for Orbit Oculoplasty and Aesthetic Services at Dr. Agarwal's Eye Hospital, Bhubaneswar. And today's panelist, Dr. Sharmishta Behra, the Professor Bhimsa Burla, Dr. Hemant Chaudhary. Currently, she is the academic in charge of Chaudhary Eye Hospital Research Center and consultant at Silchar. Dr. Soni Sinha, Additional Professor, Department of Ophthalmology, AIMS, Patna. Dr. Amit Kumar, Assistant Professor, AIMS, Patna. And Dr. Supriya Hebam, Fellow in Orbit and Oculoplasty, Ocular Oncology, Senior Consultant, former Consultancy, Sankardaba Netrale, Guwahati. Dr. Sunil Kumar, Professor HOD, RIMS, Ranchi, and Dr. Randir Jha, ex-registered squint glaucoma and neurophthalmology unit, District Netrale, Patna. So these are our panelists and discussants. Yes, we have got about 5 to 6 medical colleges, students, second year, third year residents who have joined this program. They've shown their interest to participate in this program. Dr. Khyanaprabha and Dr. Surabhi Prasad from Silchar Medical College, Dr. Amrit Sahu and Dr. Pinky Cecil Panade from MTC Medical College from Berhampur, Dr. Priya Tiwari, Dr. Soumya Parveen, and Dr. Ekta Misra from JLN Medical College, Bhagalpur, and Dr. Pragya Bharati Nanda from Silchar, Dr. Pankhudi from AIMS Patna, and Dr. Dekam Puje and Dr. Mutyunjay Khade from SC Medical College, Cuttack. So these are our discussants. For the next 1 hour, they will be discussing with our speaker, panelist, and I request these people, these discussants, to not to hesitate to ask questions. Even if you don't know the answer, please forget. But ask questions. Then only it becomes more interactive and interesting for all of us. So these few words, I welcome you once again to this program of Ophthalmology Residents Teaching Series number 36. And we propose, I think, every fortnight, but somehow due to some certain disturbances, because coming month, Dasara Puja, so probably there will be some disturbance, but however, it will continue for years to come. Thank you very much. I stop this and I make the handover to Dr. Aparna to continue the program. She is our moderator of this program. So over to you, Dr. Aparna.
Thank you, sir. Today, unfortunately, Dr. Sharmishta won't be able to join us. She has fever and cold. But anyways, so today's episode 36, and on behalf of Eizoc, we have the pleasure to welcome a very illustrious, bright mind in the field of ophthalmology and a truly global icon who has put India in forefront because of his work in neuroophthalmology, Dr. Ashwin Gandhi. He had been associated with Shankar Netralayaya, Chennai for over a decade, where along with his association with IIT Chennai, he has done some clinical research, some really groundbreaking research associating visual pathways with dementia and Alzheimer's. Currently, he is the director of Cygnus at UAE, as well as the director of the Neurophthalmology department at CFS Hyderabad. He's undoubtedly Dr. Ajit Babu Maji's best student so far. So, Dr. Rashmin, I would please invite you to start your session.
Thank you, Aparna. Thank you, Dr. Subudhi sir. As you said, my mentor and good friend, Dr. Ajit Babu, and the entire committee of Eizoc for giving me this honor. It's always a pleasure to interact with all of you. And I would request, as Dr. Subudhi sir said, I would request all the postgraduates. This is going to be an interactive, very simple session because there's an examination techniques. Now that's something which we all should be knowing, and we should be using it in our exam and also in our clinic. So these are going to be very non-complicated questions, and I would request all our residents to participate. So let's start with this case. It was shared with me with my mentor, Dr. Naveen Jaikumar. The patient traveled from abroad for a second opinion. His history was this: I was hit on the head repeatedly by the soldiers. After that, my eyesight gradually went down. He was told, you are having traumatic optic neuropathy and nothing can be done. And that's the reason why he traveled to India to say whether are there any new advances for traumatic optic neuropathy. That's the reason why he had come. So please look at this history. So whenever you are encountering a patient who has loss of vision, these are the optic nerve function tests that you will do. And we are going to discuss this in detail. But before that, let's go back to the history. Now, any one of you have any doubts about what's going on here? The patient who has traveled from abroad with this history, I've kept it there in front of you. And he said that, can something be done for my traumatic optic neuropathy? Any doubts in this history? Because history is probably the most important aspect of neuroophthalmology, because a lot of this you cannot see. The optic nerves, the optic chiasm, you cannot see. So you need to make a deduction mainly by history. So anybody from the postgraduates, would you say, is there anything which is troubling you in this history? Is this a history for traumatic optic neuropathy?
Dr. Pragyan Bharti, can you tell something about it?
Or Dr. Pankuri, come on, don't worry. Yeah. Yes, Pragya.
Yes, sir. Good evening, sir.
Good evening.
Sir, the history here is repeated trauma to the head.
Yes, very good.
Sir, that is troubling that after repeated hit, the patient complains of vision loss.
Very good. So that is one thing. You are not worried. You are not very comfortable with this repeated trauma. Anything else? Very good. So this is how you dissect. When you look at the history, you dissect each of the points. Anything else which is troubling you? What is the second part?
And the gradual loss of the vision.
Excellent. Well done. Very good. Gradual loss of vision. Please remember, traumatic optic neuropathy is a disease where the vision, because of trauma, immediately the vision goes down, and in most instances it stays there. In a small percentage, in 10 to 15% of the patients with traumatic optic neuropathy, because of a reason not known, there can be some improvement, maybe because a lot of vision loss was because of edema in those patients. Once the edema subsides, vision can improve. But gradually progressive loss of vision is not a feature of traumatic optic neuropathy. Let me ask you one more question, and either you can take it, Pragya, you've done very well, or any other postgraduate.
Dr. Surbhi Prasad.
Yes. Can you think of any scenario where in trauma, with the history of trauma, patient will say that vision is going down gradually and related to trauma? I mean, this is a little difficult, but if you are able to tell, that'll be great. Can you think of something related to the bone if there is a blunt trauma?
Dr. Surbhi Prasad is there.
Dr. Pankhuri, are you able to come up with some explanation? Don't worry, this is a difficult question. So if you tell, it's great. If you don't tell, it's fine. There's nothing wrong about not being able to answer, because this is not a very straightforward question. Okay, let me come to that. So as I said, traumatic optic neuropathy is generally an acute loss of vision. However, if because of blunt trauma, if there was a fracture of optic canal, and if that bone fragment is sitting on the optic nerve, then that acts as a compression of the optic nerve, And only in that scenario, vision can go down gradually. So the reason why I put this history is, let's discuss a patient with a vision loss, right? What are the questions, since we're talking about history, what are the questions that you'll ask to a patient who comes to you with vision loss? Now, please remember, we are not really talking about cataract, glaucoma here. We assume that those things have been ruled out, and we are now suspecting a visual pathway problem. All right. So the first question, and this is simple, what questions would you ask to somebody who comes to your OPD or in your exam to say, I cannot see? Yeah, this is simple, so we can move faster so that we can cover more cases. Anybody?
Rashmin, anybody is nobody.
Yeah,
You
so
need to ask specific names.
I don't want to ask the consultant, so that's the reason I'm
So, Dr. Ekta, can you please answer?
like, what are the
Yeah,
questions?
suggest the names. Aparna, you take that.
Yes, sir. Dr. Ekta, are you there?
Yes, ma'am.
Yeah, can you please answer?
What are the questions that you ask, Ekta? Very good. To somebody who says loss of vision.
So for acute loss of vision,
Very good. So
so
that's
any history of
first question. Whether you say whether it's acute or gradual. That's the first question. Correct?
yes, sir.
Very good. Now let's
And any history of trauma or surgery, any past surgeries, any trauma,
wait.
any history of
Excellent.
a swelling or fever.
Wait 1 minute. Wait 1 minute. 1 minute. Very good. Very good. Excellent. You're doing very, very well. But let's stick to the loss of vision. So first thing you ask when somebody says loss of vision is whether it's acute, subacute, or gradual. Right?
Yes.
Now, what is the second question in vision loss? Now, what you're saying is the associated features like trauma and all that. But before going there, anything else would you?
Whether it is painful or painless.
Fantastic. Very good. Excellent answering. So second question you ask is it painful or painless? What is the third question? Excellent. We are doing very, very well. What is the third question? So let's say a patient comes to you 3 weeks after the onset of the problem. So remember in medicine, the history, ODP, origin, duration, progress. So we said origin, let's say for example, acute, duration, I said 3 weeks. Now progression. What
Yes, sir.
happens 3 weeks? So let's say I'll give you 2 scenarios. Okay, and you tell me what do you think of. Patient tells you acute loss of vision. Scenario number 1, vision went down before 3 weeks and it just stayed there. No change, no improvement, no deterioration. Second scenario, vision went down, continued to go down for around 10 days, stabilized, and now patient says it is improving a little bit. So these are 2, origin, duration, progressive. It can be 2 things. 1, it progressed, 1, it did not progress. So what do you think of just by this history? Went down acutely and stayed there. Can you think of an optic nerve problem which will present like that? And the second scenario where it went down, stabilized, and started improving. Ekta, do you want to take it?
For the second scenario, any hemorrhage which resolved, any retrobulbar hemorrhage,
Okay, yeah.
or
Though I mean that's technically that is right, but that's not the commonest. You're not wrong, but something more common from the optic nerve point of view. So hemorrhage can resolve. What else can resolve? Hemorrhage,
Infection.
inflammation, absolutely. Infection or any inflammation can also resolve, right? So optic neuritis typically would have that history. Vision goes down, continues to go down for some time, stabilizes, and by 3rd week, it will start improving. And in most instances, by 6 to 8 weeks, vision would come back to near normal. Versus the first scenario where vision went down and stayed there, that is quite typical of ischemic optic neuropathy. Right? Each of these topics, I'm sure Dr. Babu has planned to cover in detail. So we're not going to go to each detail. We're just saying approach. So first thing you say, whether it's acute, subacute, or gradual, and what happened in the interim period. Can you think of, so acute, It can be optic neuritis or ischemic optic neuropathy. What can you think of? What can cause a subacute loss of vision, where vision went down for around a week and then it stabilized? Can you think of Sakshi? Are you a resident? Then you can take that. Or Pankhuri, you can take it. Dr. Pankhuri.
Dr. Pankhuri, are you there? Okay.
Krishnapriya is there.
Yeah. Dr. Priyanka Agarwal, are you there?
Speak.
Yeah, would you like to take it? So subacute loss of vision, generally described in hereditary optic neuropathy, which is LHON. LHON can present. LHON, what is the full form of LHON?
Leber's hereditary optic neuropathy.
Fantastic. Leber's hereditary optic neuropathy. Generally seen in males or females?
Is it females?
No, generally seen in males because the inheritance is mitochondrial. So that's the reason why the females are generally carriers, and males would have a phenotypic disease on the clinic. So Leber's hereditary optic neuropathy would have a subacute loss of vision. And now give me 3 situations where patient, like our patient, where patient will have gradually progressive loss of vision. Give me three conditions where you will find patient would have gradually progressive loss of vision. Can you think of?
Of demyelinating diseases.
So demyelinating disease generally would cause optic neuritis, which would have optic neuritis kind of disease problem where vision will go down, stabilize and improve. But here, what we're talking about is vision continues to go down. It does not improve. What can cause typically a gradually progressive loss of vision? If nerve is getting pressed. So what can press the nerve, which slowly vision will go down?
Any mass.
Exactly. Excellent. Excellent. Very good answering. The mass lesion or compressive optic neuropathy typically will cause gradually progressive loss of vision. And that's something which is very important. And that's the reason why this patient, when he said gradually progressive loss of vision, your antenna should be up saying this is not trauma. It can be a mass lesion. Anything else? 2 more conditions where vision would gradually go down. Let's say somebody who is
chronic papilledema.
Excellent, Rishabh. Chronic papilledema will also cause gradually progressive loss of vision. What else? What if somebody is consuming a lot of alcohol or smoking a lot of cigarettes?
Toxic optic neuropathy.
Very good. Toxic and nutritional, both together, generally would have progressive loss of vision. Can you think of a toxic optic neuropathy which will produce acute loss of vision? One condition.
Toxic. Methanol poisoning.
Methanol poisoning.
Methanol poisoning.
Methanol poisoning.
Yes, Rishabh, Pankhuri, both of you got it well. Amazing. You guys are amazing. Very, very good. So methanol poisoning is only toxic optic neuropathy where patient would have an acute loss of vision. Rest all generally will have a gradually progressive loss of vision. Occasionally, ethambutol toxicity can present with a subacute loss of vision, but that is not very common. Very good. So we said compressive optic neuropathy is gradually progressive loss of vision. Nutritional and toxic optic neuropathy, gradually progressive loss of vision. Rishabh said chronic papilledema will lead to gradually progressive loss of vision. One more. Remember, apart from LHON, all other hereditary optic neuropathy will have a gradually progressive loss of vision, especially autosomal dominant optic neuropathy can actually have very slow progression, and that's why they are missed initially. They can have, sometimes it is said that the autosomal dominant optic neuropathy they can lose only one Snellen's line every decade. And that's the reason why they will find this out very late in the disease. So nutritional, toxic, compressive, chronic papilledema, and some of these situations will have a gradually progressive loss of vision, hereditary optic neuropathy. All right. So first question you ask when the patient comes to you with loss of vision is acute, subacute, gradual. In acute, you say, okay, what happened? Origin, duration, progress. Did it improve or it just stayed there? So just by history, you can start classifying some of these diseases very easily. Excellent. Now we say, what are the examination technique for a patient who has an acute loss of vision? So these are the examination technique. What are you looking for in pupils in patient who has loss of vision? What test are you doing for pupils?
Checking for RAPD, swinging light reflex test.
Excellent. That's a superb answer, Dr. Pankudi. This is we will do swinging flashlight test and you want to demonstrate RAPD. What is the full form of RAPD? Full form.
Relative apparent pupillary defect.
Excellent. So now you know it's a efferent defect of the pupil. What is this relative here?
Because one pupil is normal, in relative to that pupil, there is abnormal. The other one is abnormal.
So relative is comparison of two anterior visual pathways. It is comparison of one visual pathway versus the other, and that's why it's called relative efferent pupillary defect. I want somebody, okay, Ekta, please describe how do you perform swinging flashlight test, the steps of swinging flashlight test. What are the steps which are necessary? Yes, Ekta.
So we first eliminate one pupil and we notice constriction of the pupil. Then after a gap of about, we swing the flashlight to the other pupil and then notice constriction again and then go back to the other pupil. And this time if it is dilating or constricting, we notice the reaction of the pupil.
Very good, very good. Sakshi, would you like to add to what she has said? Or who else is there? I don't know whether iPad, Samsung, there are students or faculty or Google Pixel. Yeah. Anybody else would like to venture into say that there is some more information that I would require here. You've answered it very well, Ekta, but there are few more details which are very important when you perform a swing flashlight test. Priyanka Agarwal, would you like to add that? Should patient be looking at you or looking at your torch or looking somewhere else when you perform a swinging flashlight test? Where should patient focus?
Patient should be looking at a far point.
Excellent.
Not directly at the torch.
Why far point? Very, very good. Why far point? Because if patient looks at you or your torch, he will converge and accommodate. So the near reflex, three components of near reflex: convergence, accommodation, meiosis. So pupil will constrict irrespective of the light going on the pupil or not going on the pupil because of the stimulation of near reflex. And that's the reason why patient should not be looking at you. Patient should be looking at a far object. That is very important. So point number one, patient should be looking at a far object. Point number two, it should be done in a dark room. It should never be done in a bright room because the bright room can interfere with your reading. Point number three, rest, you said it very well, Ekta. You need to make sure, because it's a relative efferent pupillary defect, you need to make sure that each pupil is stimulated equally. So in your mind, you can count 1, 2, 3. So the duration remains equal and the angle should remain equal. Then go to 1, 2, 3 and go to the other part. 1, 2, 3 and come back to this. So that's how you swing to make sure that the duration of the pupillary stimulus remains the same. We will talk about RAPD a little more. First, we have spoken about all other tests. What is the role of color vision? How do you check color vision? Question number one. Question number two, what is the role of color vision in the patients with optic nerve disease? Anybody? How do you check color vision generally in your OPD?
Sure,
Ishihara chart.
Excellent, excellent. Pseudo-isochromatic plates, Ishihara chart. How do you use them? What are the conditions that you need to follow when you're checking color vision with Ishihara chart? Should it be done in a dark room or a bright room?
Bright room.
Very good. Bright room. You need to make sure that the book is properly illuminated. Should it be done with the glasses on or glasses off?
Glasses on.
Google Pixel 9a, yes, glasses on. Absolutely right. Absolutely right. Okay. What if patient's vision is N6, but he says, I cannot see even what is the first letter in Ishchara?
12.
12. What patient says vision is good, but he cannot see 12?
Malingiri.
Excellent. Xiaomi, very good. If that is a test plate, and everybody who has a decent near vision should be able to read that 12. Okay, great. So we said color vision is tested by pseudo-isochromatic plates. The plate should be well illuminated. Near vision glasses should be on. And the first place is a test plate. Is there any other role of this? What is the other role? Is there anything else that the color vision can tell you?
So cortical blindness.
So when differentiating between a papillitis and a papilledema, the color vision will be lost in case of a papillitis. There will be some diminution in the.
All right. So one thing.
Macular disease.
Yes.
Macular disease.
Go ahead. No problem. You're all doing very well. Excellent. Your answering has been superb. Very, very good. Yeah.
Does it indicate any macular disorders?
No, so it can. However, it is much more sensitive to the optic nerve disorder. Now, as Rishabh mentioned, color vision can differentiate between different types of optic neuropathy, because the color vision deficiency can be different in different kinds of optic nerve deficiency. So what is the example? The example is this. It can, in a optic neuritis, the color vision deficiency would be much higher than the Snellen's visual acuity deficiency. Patient can have a 6/9 vision, but the color vision generally would be wiped out. Versus ischemic optic neuropathy, where the visual acuity, Snellen's visual acuity, and this would go together. So if there is a moderate visual impairment on Snellen's, then there'll be a moderate visual impairment on the color vision as well. So that's how you can differentiate. Just by looking at the color vision, you can differentiate between optic neuritis and ischemic optic neuropathy. And as Rishabh mentioned, you have to also remember that papilledema, at least in the initial period, does not cause optic nerve dysfunction. If papilledema is not treated, then it is potentially a blinding disease. So all these pupils, color vision will get affected a little later in the disease. So in an acute, somebody with an acute disc edema, and if everything is normal, possibility is either it's a pseudo disc edema or it's a acute papilledema. All right. Now let's look at the visual fields. Do you know what is the? We have now the Humphreys visual fields available almost everywhere. So what's the point of doing confrontation? What's the point of doing confrontation? Anybody? Why would you like to do confrontation? What is the utility? In other words, what is the utility of confrontation in somebody who, are there any, can you think of situations where confrontation can be the only thing available to you? So the utility of confrontations are following. When you have a patient who has very poor vision, 2/60, 3/60 vision, those are the patients who are not going to respond, okay, to your visual field testing. You will not get meaningful information out of your visual field testing. If the patient is in the ward and non-ambulatory, has a neurological disease, has a stroke, those patients will not be comfortable sitting on the perimeter and respond to your commands meaningfully. Children, mentally unstable patients. So these are the patients where the confrontation has a role to play. Would anybody be able to tell me how do you do confrontation? How do you do confrontation? What are the ways by which, what is the first step? First step of confrontation. Anybody?
Yeah, come on, Pragya. First step, how will you arrange yourself in front of the patient?
She has already given you a lot of clue.
So the patient and the examiner should face each other.
Face each other, and
Yes, yes.
the fingers should come from temporal to
No,
the
level.
Yeah.
Same eye level.
Sorry?
They should be sitting at the same level, same eye level.
Yes, exactly. Very good. Then?
If we are supposed to check the left eye of the patient, then then the examiner should close his own left eye, and then should start bringing any object like a pen or finger from temporal to the nasal side, and then observe at what point the patient is able to appreciate the object.
Okay. So please remember, confrontation has several steps where in the initial steps, you don't really need to close your eye. So what is the first step? As you very rightly said, you're sitting in front of the patient, the eyes are level, you are at around 1 meter distance. Now, please remember, would you do it with glasses, without glasses? Confrontation, somebody has a refractive error. Would you do it with glasses, without glasses?
With glasses.
Sorry?
With glasses.
With glasses? Let me show it to you. So it is done without glasses because if somebody has a little higher refractive error, it will interfere with the peripheral vision, not because his field is bad, because of the peripheral thickness of the glasses. So it is done without glasses because it is done only at 1 meter. So the first step is where patient closes the eye. Let's say I'm the patient. So I've closed my right eye. So now you're testing my left eye. Just assume that I've removed the glasses. So now there are 3 questions that you will ask without closing your eye. First question, can you see my face? All right. So if patient says, oh, I cannot see your face, you know that patient's vision is very poor and you may not get meaningful information. And this is something which Dr. Ajit Babu will say. He's a very reputed FRCS examiner. So a lot of times what happens is a British examiner they used to do is they will keep somebody with no PL and say that, oh, do confrontation. What they want to tell you is that first just check the vision for you to make sure that you are able to get a proper information of confrontation. So simple way of doing it is patient closes the eye and say, can you see my face? Patient says yes. Okay. Question number 2, can you see my nose? Patient says yes or no. Patient says yes, very good. Patient says, no, I cannot see your nose. I can see your face, I cannot see your nose. You know, maybe you are dealing with central scotoma. Third question, when you're looking at my nose, is any part of my face missing? That's the third question. Can you see my face? Can you see my nose? When you're looking at my nose, is any part of my face missing? Now, this is a joke that I tell a lot of times, that this is something which really happened, and that's why it's not a joke. I was doing this demonstration in Chennai on a patient, and that patient was otherwise a normal patient, but a very smart or little over smart patient. So I asked him this question, can you see my face? He said, yes. Can you see my nose? He said, yes. So I asked him the third question, when you're looking at my nose, is any part of my face missing? So he said, hair. I said, that doesn't count. You need to look at the neurological deficit. So these are the first 3 questions. Once now you've gone to say that, okay, If any part of face missing, means if upper half is missing, maybe there is an arterial defect, superior arterial. If lower half is missing, inferior arterial. This part is missing, temporal. This part is missing, nasal. So you already get the heminopic defect just by asking these three questions. Step number 2, even here, you don't close your eye. So patient has closed your eye between, so at a half a meter. So if my screen is my patient, so here in either side of the midline, I'll project finger and I'll ask the patient count. How many? How many? Then I'll go down and say how many? How many? So if here patient is not able to see, you know there is a superior defect, inferior defect. If here I'm not able to see temporal, if here I'm not able to see nasal. So even at this step, you don't need to close your eye. You can just do this and figure out if patient has. In most of the exam cases, we are talking about the exam and clinic as well. So in the exam cases, you're likely to get a very advanced defect which you can figure out. It's very unlikely that they'll give you a defect which is just a relative scotoma somewhere, small scotoma, which is you'll fumble. What examiner wants to know is, do you really know the technique? And examiner like Ajit Babu, just as you sit, they will know whether you've done it or you're doing it for the first time. Have you practiced it or not? So these are the 3 steps that you do. If after that everything is normal, is where what you said, you need to get it from the periphery, bring it to the center and say, where is the target? Patient is able to see the target where? I mean, if now I'm able to see it here, but the patient says, I cannot see, I cannot see, I cannot see. He's able to see it here only. I know that patient has a scotoma here, and then I need to chart the boundaries of the scotoma, saying what areas of that particular region patient is not able to see. So what is the role of confrontation? Poor vision, children, mentally subnormal patients, or bedridden patients. You cannot do full Humphreys field, and that's why you should be knowing about confrontation. All right, so that's about confrontation. Let's continue with our presentation and say that what else do you see? Emsler. Now, generally, Emsler is used to figure out metamorphopsia in retinal conditions, but please remember, it also gives you an excellent information about the central 5 degrees. How do you perform the Emsler charting? Pragya, how do you perform Emsler charting? What are the steps? Is it done in a dark room or a bright room? Anybody? Dark room or a bright room? It's done, Rishabh, how do you do it? It is done with the light falling on the Emsler chart. It has a central dot. So again, the same thing. You ask the patient to look at the central dot and say, can you see the dot? When you're looking at the dot, can you see all 4 corners? And when you're looking at a dot, are any lines missing? So if any of the corners missing, you know that there is a scotoma there. If any lines are missing, then you know there is a scotoma within that central 5 degrees. Red target, red desaturation is probably one of the earliest signs of optic nerve and optic chiasm problem. So there are 2 ways by which you would perform the red desaturation test. You take a small pencil. Now, in the first test, you ask the patient, it is done monocularly. You bring the red pencil from the outside, not very far, from the outside, crosses the midline and goes here. And only question that you're asking is that when you're moving, does the color change? In most instances, when patient has a subtle central scotoma, patient will say, oh, it became brown when it came to center, and again it became red. When the patient has pituitary adenoma, what is the visual field effect in pituitary adenoma? What area of the visual pathway will be compressed in pituitary adenoma? If there is a pituitary gland problem, will it compress optic nerve? Will it compress optic chiasm?
Optic chiasm.
Chiasm.
Very, very good. Excellent. You guys are very good. So it compresses optic chiasm. So what kind of visual field effect you will get when there is a compression of optic chiasm?
So bitemporal hemianopia.
Bitemporal.
Very good, Rishabh. So you get bitemporal hemianopia. However, in the early stages where the pituitary adenoma is just developing, you may only have a red desaturation of the both temporal side. So when you do this red desaturation, when the patient says that when you start from outside And when you move it like this, patient says, oh, from here it becomes bright red, here it's brown or black. So those are the early signs of pituitary compression and optic nerve compression. So these are the visual field testing that you will do, which is confrontation, Amsler, and sort of a charting of the visual field using red target. There is one more test called brightness sensitivity. You should be aware of it. It's not performed so easily, so commonly. Is that you ask the patient to look at the torchlight. So in a dark room, now patient looks at the torch and you do alternate cover test. And you ask the patient, is there any difference in the brightness between two eyes? This works very well in somebody who has a monoocular optic neuropathy. So if patient has a right optic nerve problem, when you do this, he will clearly see that the brightness is lower, brightness of light on the right side versus the left side. And in few situations or in few people would use it to follow up. He will say that, oh, has it now improved after a week or 2 weeks? So that used to be one way by which you would monitor the recovery of optic nerve function. So brightness, these are the optic nerve function tests. We are talking about examination techniques in neurophthalmology. The first topic that we picked up is loss of vision, and these are the examination technique that you will go for. Of course, fundus is not really an optic nerve function, but it's an examination technique you should be aware of to make sure that you don't make a mistake. Like
Rashmin, can you tell about 1.5 syndrome?
Yeah, sir, I have an ocular.
Craniopharyngium a little bit so that they can identify.
Yes. So now, so there are two things. Dr. Ajit Babu, because he's an examiner, he knows what topics he is going to ask you. So there are two things. One is chiasmal compression. So I said pituitary adenoma, which pituitary grows from below and compresses the chiasm from below. However, the optic chiasm is right in the middle. It can get compressed from above. So above optic chiasm is third ventricle. So craniopharyngioma is an outpouching of the third ventricle, which can compress the optic nerve from optic chiasm from above, again causing bitemporal hemianopia. However, the differentiation is if it compresses from above, the bitemporal hemianopia will start from below and will go up. If there is a pituitary when it compresses from below, the bitemporal hemianopia will start from above. So there will be a superior defect in both temporal parts, and then it will break into a complete bitemporal hemianopia. 1.5 syndrome is an oculomotility disorder which is generally seen in brainstem. So there are three different, when you have a brainstem problem, there are three different kinds of bilateral oculomotility problem that you can see. One is what is known as INO. What is the full form of INO?
Internuclear ophthalmoplegia.
Very good.
Ophthalmoplegia.
Where is the lesion in INO? What tract? M?
Medial longitudinal.
MLF, longitudinal fasciculus.
Superb. Medial longitudinal fasciculus. Now, if there is only one side MLF problem, you have INO of that side. If bilateral, both sides MLF is gone, which can happen in multiple sclerosis, then you have a syndrome, what is known as?
Webino.
Very good, Pragya. Webino, wall-eyed bilateral interlocutor. The third part is what Dr. Ajit Babu wanted to highlight is 1.5 syndrome. Does anybody know where the lesion would be in 1.5 syndrome? In 1.5 syndrome, so you have MLF and then you have
Horizontal gaze palsy with iron.
Very good. Excellent. PPRF, parapontine reticular formation, which controls the gaze to the same side. So if somebody has, let's say, right PPRF problem, patient would not be able to abduct the right eye and adduct the left eye. Can't see to the right. So there is already, these two movements are gone. Now the same lesion, let's say there's a tumor of or demyelination, goes a little above and also presses on the MLF on the same side. So now remember, this eye is not abducting because there's a gaze palsy. Now because there is an MLF of the same side, this eye will not adduct also. Whereas MLF is adduction deficit of the same side and abduction nystagmus the contralateral side. So this eye is not abducting, this eye is not adducting, and now this eye is not adducting because of gaze palsy. Only movement which is remaining now is the abduction of the left eye. So that's why 1.5. After the two movements, 1.5 is gone. Only 1/2 movement is remaining. So that is 1.5 syndrome. So these are ocular motility syndromes, which we'll come to later. Today we said the acute loss of vision and what all would you do. So I included fundus as a part of recognition of optic nerve problem. So even here, there was a clue. Remember that patient who came with a repeated head injury, gradually progressive loss of vision? Patient had a problem with the right eye, and yes, there is a right optic atrophy. Is there something else that you can see here? What else do you see here?
Pallor of the disc in the right eye.
Excellent. Very good, Pragya. Pallor of the disc of the right eye. Rest, everything looks normal. Anything else? Obviously, because I'm now showing the other eye also. Now, what do you think about the other eye? So in the other eye, if you see, this is the left eye, which is otherwise patient does not have a problem here. You see, this is pink. This is pink. But this is pale. This is pale. Okay. What fibers get attached here? Fibers which make like this. What are those fibers called?
Arcuate fibers.
Excellent, Dr. Pankodi. Arcuate fibers. Which disease predominantly can cause a problem with the arcuate fibers?
Anterior ischemic optic neuropathy.
No, Xiaomi. Ocular disease. It can. You're right, Xiaomi. Theoretically, you're right. But what ocular disease will have elongation of the cup vertically because these fibers are gone?
Glaucoma.
Glaucoma.
Exactly. So this is predominantly affected in glaucoma. Now, what fibers are getting attached here? What is here?
Papillomacular bundle.
PMB, papillomacular bundle.
Macular bundle gets attached here, and the nasal fibers get attached here. So basically, here is the other eye where patient does not have a problem. You said nasal fibers are gone. So these are nasal. Nasal to what? Nasal to macula. It's a papillomacular bundle. These are nasal fibers. They get attached here. The arcuate raphe, temporal raphe goes like this. So they are fine. So patient has what is known as bow tie optic atrophy or a band-shaped optic atrophy. All right. This is another feature of. So now I said that nasal fibers are gone. What kind of visual field effect you will see if somebody has a nasal fibers which are gone? If
temporal, since the nasal fibers crosses at the optic as well.
Nasal fiber is gone, patient will have a temporal defect. No, not even crossing. It basically, because the anatomy, the light falls here, it serves the temporal field. Light falls here, it serves the nasal field. So here, this is serving a temporal field which will gone. So again, come back and say, which problem, if there is a compression, where would you find a temporal defect? Chiasmal problem. So here, now, can somebody say what kind of visual field effect would you expect here? This is optic nerve gone, and here I am saying nasal fibers seem to have gone. There is a specific visual field effect that you will see here, which has a name also.
Problem in optic chiasma.
Yes, a problem in optic chiasma. What kind of visual field effect you will see here? Very good, excellent, you are right.
Bitemporal hemianopia.
Yes, bitemporal hemianopia, generally you will expect a symmetrical optic nerve. Here, this optic nerve is damaged more than this, right? This is like completely gone. So, patient can still have bitemporal hemianopia, but more likely, what kind of visual field effect we find here? The
hemifield slide.
No, hemifield slide is not a kind of visual field effect. Hemifield slide is an ocular motility problem. Here, what you have is the optic nerve is completely gone. So here you'll have a generalized reduction of sensitivity. There'll be a black field because visual acuity is likely to be very poor. And here, let's say if I say the patient had a supratemporal defect. Now, are you aware of a visual field defect which can cause optic nerve kind of defect on one side and only supratemporal defect on the other side? What is it called? It goes by the name of the scientist Trackwire. What visual field defect was described by Trackwire? Junctional scotoma. Okay? You will find in these patients, you can see here, I've highlighted, this is the bow tie optic atrophy, and this is junction scotoma. This is from some other patient where it's a left eye, the vision is gone, and just the supratemporal. How do you know this is temporal? Why not this nasal? This can be nasal also, no? How do you know? I have written here right eye if I had not written here.
So the blind spot will be present temporarily in the field.
Excellent, Dr. Shade. Dr. Shade, very good. This is a blind spot here on the right side, and that's the reason why this is the right eye. And so this is temporal, and this is why that's a supratemporal defect. So this is a classical junctional scotoma of trachea. And you know that this patient would have optic chiasma problem, and you do MRI scan, and you find here that there is a pituitary adenoma which is causing this problem. So we discussed this scenario of pale disc and progressive loss of vision. We said that these are the three causes of progressive loss of vision. We also know that there can be a pale disc with the blood disc margin, and Rishabh had mentioned about raised ICP. So I just want to now, to conclude, we'll continue the history part and say that 24-year-old female who complains of headache, very mild visual symptoms, vision is 6/6, and this is how her optic nerves look like. What do you think is happening here? 24-year-old female, I can tell you that she's little overweight. She also has polycystic ovary disease, has headache, and has a very mild visual symptom, nothing else. What do you think is happening here? How do the optic discs look like? Are they normal?
Blood margins.
Blood margins. So now there is a 24-year-old little overweight female who has a polycystic ovarian disease with her estrogen progesterone levels are continuously fluctuating and has headache. So what is your first thought? What can be the first mechanism of having these problems? This is raised intracranial pressure. This is papilledema. Of course, you will check for the blood pressure to make sure that they are not dealing with malignant hypertension. Sometimes malignant hypertension can be seen in a young patient, let's say somebody who has pheochromocytoma, but this is raised ICP. So let's just talk about the history points and conclude. What history points would you ask in somebody who has a suspected raised intracranial pressure? What are the points in history we would ask? Yes, Dr. Pankudi, Dr. Ekta, Dr. Pragya, you guys are amazing. I mean, your answering is like very
Symptom of nausea or vomiting.
Yes, nausea, vomiting, headache, I've already spoken about. What are the other symptoms which we often don't ask, but we should be asking? One is transient visual obscuration. These patients do complain of transient obscuration of vision, which is a very, when present, is a very suggestive symptom. Not everybody has it, but a lot of patients, 70-80% would have it. When they have it, you say that, oh, I have to think of raised intracranial pressure, transient visual obscuration. How does transient visual obscuration of papilledema differ from transient visual obscuration of somebody who's having, let's say, carotid problem? TVO, transient visual obscuration of papilledema, generally will last only for a few seconds, while the carotid artery disease, TVO, will last for a few minutes. Patient will say, oh, it was all blurred for 5-7 minutes and then it became all right. TVO, he said, oh, it was blurred for a few seconds. Second characteristic, TVO in raised ICP is posture related. Patient would very clearly say, when I got up from a lying down position is where I got TVO, which lasted for a few seconds, and typically described as browning out of vision. Patient will say, oh, everything became brown, not black, brown, and then it cleared up in few seconds. So TVO you should ask for apart from headache and vomiting, and you should also ask for tinnitus. Again, when present, it's a very important symptom. It's described as a whooshing sound in both the ears. So these are two symptoms that you should always ask for in these patients. So I just wanted to cover the examination techniques would include, we have covered the efferent part, and at some point, if Dr. Babu and Dr. Subudhi feels appropriate, we'll also talk about the efferent at some point because that's also a very large topic. But I wanted to cover the optic nerve and the loss of vision in little more detail because that's something which is the commonest symptom, and you should be aware. Make sure that list you are aware of: visual acuity, pupil, color vision, visual field charting. Visual charting, we have three things, and all those things should be looked at. I'm sorry. Okay. All right. So I think I'll conclude with that. We have we have 9 o'clock. So any other questions that you may have, I'm very happy to answer.
I would request our panelists to put in their own views and the students to ask whatever questions. And we'll keep it short, maybe wrap it up in another 5 to 10 minutes.
We have time. It is only 9 now, Aparna.
Okay, so
Education is a pleasure, I should say.
Dr. Sunil Kumar. Dr. Hemanti.
Sir, contrast sensitivity, is it significant to check in the optic nerve function test?
Yes, contrast sensitivity is an excellent question. So contrast sensitivity is a very important optic nerve function test, especially in optic neuritis, because that can be the only, apart from color vision, loss of contrast sensitivity can be the only feature in the initial period of optic neuritis. So yes, that's a part of, apart from brightness sensitivity, contrast sensitivity also is a part of an optic nerve function test. I did not cover here because a lot of times we don't have an access to those charts. But yes, in the exam, we should mention. Very good point.
Okay, MRI, good evening, everybody. So should MRI brain be part of the neurological workup for any patient who will be presenting with a sudden onset loss of vision?
Yeah, of course. I mean, since today it was only the examination techniques and clinical part, so MRI generally would be covered, let's say, when we talk about optic neuritis. If you're suspecting optic neuritis, what MRI should be requested for? So you're absolutely right, Dr. Chaudhary. MRI is integral part of everybody who has an acute loss of vision. Everybody. 20 years ago, we used to say that, oh, MRI kiya, it's okay. If you didn't do MRI, no problem. But now, because of these newer antibodies which are causing optic neuritis, we need to do MRI in everybody who has an acute loss of vision because it can be picked up early. CT scan has no role to play in optic nerve disease except if you're suspecting an orbital disease. Otherwise, always MRI, brain and orbit with contrast. Not only MRI brain, MRI brain and orbit with contrast. And if you are able to mention what are you suspecting from a clinical examination, then radiologists will do appropriate sequencing like FET separation in somebody who has an optic neuritis.
Aparna, please take charge. You are muted actually.
yeah. So the students, if you don't have any other questions for Dr. Gandhi, they are all silent. Yeah. So, okay, then I guess we should conclude by now.
They're scared of him.
No, I want to ask one more question then.
Yeah, sure, ma'am. Please do so.
Yes. I want to ask about the perimetry, like when suppose this is a case of optic neuritis and we have done the ONTT trial for the patient. So what about the perimetry? Like, are we expected to repeat the perimetry also? Like once at diagnosis and then again after the treatment is done? What should be the way to go?
Yeah, so perimetry and nowadays even OCT should be repeated because those are the indicators of the recovery of, sometimes you may not have the recovery on the Snellens so often, but these allied visual function tests would show a recovery. So perimetry should be repeated in, let's say, somebody who has multiple sclerosis, query, multiple sclerosis or NMO related optic neuritis. You're worried about the relapse. So not only that the perimetry will show the recovery, it can also show an early relapse. The patient is not complaining. Patient's vision anyway is poor. So you say that, oh, it's 636, I'm okay. But the perimetry, there are two things you look at perimetry. Of course, I mean, it's not entirely for postgraduates, but we can discuss. So you are looking at Fowell threshold if it's available, and you're looking at mean deviation. So if you say that mean deviation is going down, you know that that patient is losing some amount of fields, even if the chart looks normal. But if the mean deviation in a visual field which is reliable is going down, you know that that patient has to be treated. Similarly with OCT, RNFL, and GCC, macular cube. So if you find that patient is losing his JCC during recovery, you know that this patient, let's say this is especially important when you're following up patient with papilledema. So neurologists have started acetazolamide. Sometimes they start only with 750 milligram. But when you look at OCT and you say, oh, GCC is going down, you need to call up neurologist to say, please increase the dose because this patient requires an aggressive treatment. Even if the patient's complaints are not commensurate with what we are doing, OCT is an ideal tool for following up. So both HPF and OCT should be repeated every month.
Okay, now if there are any other questions, it is fine. Otherwise, I have some more.
Ma'am, please do ask.
Okay. So one more question is I want to ask about the anti-tubercular, mainly ethambutol-induced optic neuropathy or the vision loss that occurs on patient on anti-tubercular treatment. So please tell us, Dr. Gandhi, like what should we do? Okay, we will write to the internist, please change the ethambutol. But then are there really chances that the vision gets a little bit better, or what is your take on these cases?
So it can go either three ways. Number one, this question is we need to be aware because now recently the national program has changed the TB regime, where now ethambutol has now to be continued for 6 months, not initial 2 or 3 months. So now we are going to see patients, because it's partly dose dependent, we may see more patients with ethambutol toxicity than what we used to see before. Now, however, at the same time, it's not that common. Of course, we see because we have a referral bias because we end up seeing those patients, but there are like hundreds of patients, thousands of patients who take ethambutol. Not everybody ends up with toxicity, but we should be aware. Now, red desaturation is one of the early signs of ethambutol toxicity. It can go all three ways. Once you ask the neurologist to substitute ethambutol with some other medication, there's a possibility vision will improve. There is a possibility vision will stabilize. There is a possibility vision will continue to deteriorate because ethambutol also affects the mitochondria. So now there is a thought process that somebody who has a problem has a chromosomal abnormality, which makes him susceptible for hereditary optic neuropathy. He takes ethambutol, that gets triggered. So those patients would not improve, or for other patients' metabolism. So for the reasons not known, it can go all three ways. But of course, we have to take a chance and make sure that we stop ethambutol. Color vision, red desaturation are excellent markers of ethambutol toxicity.
Thank you.
So
Ma'am, any more questions?
Yeah,
I have one
yes,
more. If I'm permitted, I can ask one more.
Sure, ma'am.
Yeah. I just want, because the PGs might not know, but this we get in our clinical practices, AIOL, like just tell the postgraduates how to differentiate between a non-arteritic AION and the optic neuritis.
Yeah, sure. I mean, as I said, today's class was only examination technique.
No, I know. I know, but I'm also anxious. Like I just thought when I'm having you as a speaker, why not ask few questions?
No. What I'm saying is, one might feel saying why it was not covered, but it was not covered because it was examination.
No, that is absolutely fine.
So the AION is a disease generally of a patient above the age of 40. The typical history is, as was discussed, acute painless loss of vision, which does not improve. The most important feature of, we're talking about, so AIN is of three types: non-arthritic, arthritic, and PION, which is ischemic optic neuropathy. So a non-arthritic anti-ischemic optic neuropathy is generally seen in between the age of 40 and 60. Vision goes down and it stays there. You will have, the clinical features are small disc with a small cup in the same eye or in the other eye as well. So you have disc at risk. The typical visual field defect is altitudinal defect. And these patients, generally speaking, would stay at the same level. Now, what are we supposed to do? We need to make sure that if it's below the age of 40, all those patients, we should look for homocysteine level, because hyperhomocystinemia can now produce ischemic events even in a younger patient. All patients now, you should ask for history of snoring. Sleep apnea is a contributory factor to AIN. And in the present days, apart from amiodarone and Viagra, the medical drug-induced AIN, there are reports now that these weight loss inducing drugs like Mounjaro and Ozempic can also be associated with, we don't know, there's no association which is proven, but there are reports saying that those patients have developed some ischemic optic neuropathy. Optic neuritis generally is painful, more instances of RBN versus papillary disc edema. However, one caution, and this is again not for PGs, for us as a clinician, that the optic neuritis caused by, let's say, MOG antibodies or NMO antibodies will produce papillitis, will produce optic disc swelling, can be seen in older patient. Initially, we used to say that optic neuritis is generally seen in 20s and 30s, but now this antibody-induced optic neuritis can be seen even in older patients at the age of 40 or 50. So, though clinically it may look like AIN, it might be a prudent, if patient can afford, to get the MRI done, just to make sure that we are not missing on NMO-related antibody, because if you miss that, then there's a likelihood that that patient, one, because if the patient has antibody-induced optic neuritis, they require immunosuppression for longer period of time, and those patients are susceptible to develop paraplegia. So those patients require a very aggressive treatment. So that's why we generally, 10 years ago, we would have said, oh, AIN clinically, non-arthritic AIN, no MRI required. But now, if you know it's non-arthritic AIN, but you don't want to miss out something which can be bad, so it might be a good idea to get the MRI done, unless it's a very clear cut of sectoral pallor, sectoral edema. Then you say, okay, we will follow it up. Rishabh, you wanted to ask something. I saw Rishabh raising his
Sir, actually, sir, we had a patient a few days back who had presented with gradually progressive decrease in vision in one eye. On examining, anterior segment was normal. There was presence of the unilateral disc edema in that patient, but somehow the patient did not complain of any pain, or the vision, the best corrected vision was 6.6 in the right eye, and the affected eye which had the disc edema, the vision, best corrected vision was 6.12. So the color vision was normal. So as you mentioned that in case of a papillitis, in optic nerve disease, where in case of a papillitis where color vision would be affected, so how would we approach this patient? Because we got a perimetry done in order to rule out where if there's a enlarged blind spot or there's a central scotoma. So the patient had a small central scotoma. Foveal threshold was also slightly reduced. It was 27 decibels as far as I remember. So how would we approach such a patient if the patient is a non-affording patient, cannot afford to get an MRI done? Or is it absolutely essential to get an MRI done in order to confirm whether it's an optic neuritis?
What is the age of the patient?
It was a 34-year-old female patient.
We have to do MRI. So it's like, patient may not afford a cataract surgery, but if patient has a hypermature cataract with a capsular leak, we have to do the cataract, otherwise patient will be in trouble. Something similar. Though MRI patient is not affording, but now here is the question of patient's neurological condition lifelong, and sometimes even life. So that's the reason why it might be a good idea to get the MRI, because 34 ischemia is not that common. So now you're looking to rule out inflammation, and also looking to rule out antibody mediated. Please remember, you can, in this age group, there can be a lot of surprises. You can find if the disc edema was like very severe, apart from routine optic neuritis, it can be tuberculosis, can be sarcoidosis. It can also be leukemia. So it's very important, though these are rare, but because they are fatal or morbidity is high, MRI should be, you should be able to counsel and say that MRI has to be done.
Okay. Thank you, sir.
So going back to the first case that you had told, the trauma one, who said that they hit me repeatedly and then I lost. The one disc pallor, which was glaucomatous, and the other disc which show a bow tie. Was it that patient's fundus photo?
Yeah, so it's not, one eye was not glaucomatous. The patient had an optic atrophy.
So that
Optic
was okay. So that was traumatic optic
Wasn't better.
atrophy.
Yeah.
No. That patient had a pituitary adenoma. Trauma was incidental. That's why we said that it was missed by the previous group. They gradually progressive loss of vision. And he said, oh, trauma, jao. But gradually progressive loss of vision, they never did neurology. So bow tie optic atrophy is seen in chiasmal compression. So that patient had a pituitary adenoma, which was more towards the right side. So it compressed, while it compressed the chiasm, it also compressed the right optic nerve. So that's why the right side got completely atrophic. And because there was a compression of chiasm, the other eye got a bow tie optic atrophy.
Okay. Yeah. Thank you, sir. Okay. So shall we conclude? Hemanti ma'am?
Yes. It's okay, huh? Yeah, sure.
Okay. Thank you so much, sir. It was really enlightening. It was a brush up of knowledge for all of us. And I was taking notes also. It was a really good session. Over to Subudhi sir, Maji sir, whatever you want to add, and then we'll just let Dr. Gandhi have his dinner.
No, we have lined up means topics are there in neurophthalmology. This is the first topic actually. As a first speaker, he faced a lot of questions which are means out of course. Examination techniques is the topic, but here the optic neuritis we are likely to cover. Papilledema separate course is there. Then pupillary reactions is another separate session like that. 20 topics we have chosen, and Rashmin was this first speaker. That's it. So we'll have the other topics presented in next few months.
Okay, sir. All right then. Dr. Subudhi? Yeah.
So I think I should have to give the Thanksgiving ceremony, I would say. So I must thank Dr. Asmin. And I think last year or before last year he was with us. I think it's the same topic and some different topics. I think this is amazing, and sometimes new things have also added here. So thank you, Dr. Asmin. And I hope again we'll be meeting maybe after 1 year once again. And thank Dr. Ajit Babu charting out the program for next few months, and the speakers also. And I thank our president, Dr. Jayant Purva, and Dr. Devasis, our secretary, and the Nitin Dira, chairman scientific committee, be present throughout the webinar and listening to the very interesting topic. Thank you, sir. And Dr. Hemanti, no doubts. She's a good panelist, I would say. So always welcome to go out of topic out of syllabus, asking questions. So thank you very much, keeping everybody engaged, and everybody learned a lot from the not only the neuropathy examination, also from clinical point of view. And I thank all the panelists and also the post-grad students. Few of the post-grad students really answered very well. And it's nothing hesitate. Don't hesitate to ask questions and don't hesitate to answer, because these are the only some sort of preparation for your future. So don't shy away asking questions. So thank you everybody for joining this webinar. It's a really wonderful webinar, and look forward to next few days. We'll go for the second webinar shortly. And thank you, Enter Pharmaceutical, providing the platform. Thanks all. Have a good night. Bye.
Thank you, sir. Good night.
Thank you.
Good night. Thank you, Rashmin.
Bye bye.